Good evening. Thank you for joining us for tonight's seminar, Living with Ovarian Cancer, organized by the Florida Society of Clinical Oncology. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. Many of the individuals participating in the webinar tonight are FLASCO members, and we appreciate their support. My name is Robert Holloway. I'm a physician at the Advent Health Cancer Institute in Orlando. I serve as medical director of the Gynecologic Oncology program and will be serving as both moderator and a presenter for the webinar tonight. Our oncology experts and I will discuss ovarian cancer and treatment options, as well as more individualized focused areas, including support for caregivers and patient advocacy. We'd like to thank AstraZeneca for sponsoring this webinar tonight and making it possible for us to share this important information. Before we begin the presentation, I'd like to let everyone know that this is a webinar that is recorded, and for those of you who were unable to attend can view at a later time. Also, your lines will be muted for the duration of the webinar. Toward the end of the meeting, we will host a Q&A session, and we encourage you to submit questions or comments via the on-screen questions box on the GoToWebinar panel. We will discuss as many questions as time allows. It's an honor for me to introduce our accomplished group of panelists for this evening's webinar. I will briefly introduce them now, but please read their impressive bios in the meeting packet that has been emailed to you. The link to download this meeting packet is also in the handouts box on your GoToWebinar panel. Our first panelist is Natalie Mckenzie, a gynecologic oncologist at Advent Health Cancer Institute who serves as director of the Gynecologic Oncology Fellowship Program. Our next panelist is Dr. Tim Nguyen, an oncologist at the Cleveland Clinic in Lauderdale, Florida. Also joining our panel is Marlene Morales, a licensed clinical social worker at the Sylvester Comprehensive Cancer Institute in Miami. After the Q&A, we will hear from our final panelist, Dr. Michael Diaz, who is the Assistant Managing Physician for Florida Cancer Specialists and Research Institute and Director of Patient Advocacy for FLASCO. Thank you to all of the panelists for joining us tonight and sharing your insights with living with ovarian cancer. If you could move to my presentation. What is ovarian cancer? So what is ovarian cancer? Seems like an odd question, doesn't it? But ovarian cancer really represents many different diseases that can start in the ovary, and actually many start in the fallopian tube. When most people think of ovarian cancer, we're thinking of a cancer that usually occurs in an older aged woman, median age in the early 60s. And this is typically epithelial ovarian cancer, the first one listed to the right, which includes several different histologies: high-grade serous, the most common, endometrioid, clear cell, mucinous, and undifferentiated. There are also a specific separate type of epithelial cancer called low-grade serous cancer that has a different biology and a different behavior. These cancers probably originate from the distal fallopian tube and go through a process of dysplasia or becoming malignant that eventually invade the ovary, and oftentimes what we call ovarian cancer is actually fallopian tube cancer, and difficult to separate in a large tumor mass. Why does it develop in the distal fallopian tube? We're not sure, but this is an entry point to the outside world, up through the cervix, the uterus, out through the fallopian tube. So theoretically, it's a multi-stage process that involves exposure to environmental toxins, perhaps other oncogenic agents, and then gene mutations that develop or acquired that express themselves in this epithelium that is in contact with the outside world. The next type of ovarian cancer listed is germ cell tumors. Germ cell tumors tend to occur in younger women from adolescents up into early 30s. And these are included as dysgerminoma, endodermal sinus tumors, immature teratomas, and choriocarcinomas. This makes up about 5% of ovarian cancer. And stromal tumors are the third category, which are a more connective tissue type tumor that are sometimes hormonal producing, sex cord stromal tumors, and then granulosa cell tumors, which cover a spectrum from young to older women. Again, this makes up about 5%. So 80 to 90% are in the epithelial category, about 5% germ cell, 5% stromal. The majority of the discussion tonight will revolve around the epithelial carcinomas, which are the more common type. These are also the ones that have a genetic basis as opposed to the germ cells and the stromal tumors. Next slide. There are about 23,000 new cases of ovarian cancer in the United States and almost 250,000 in the world. The chance of getting ovarian cancer is about 1 in 78 or 1.4%. This results in almost 14,000 deaths in the United States in 2019 and about 150,000 deaths worldwide. And this is now the 5th leading cause of cancer death in women, which has actually dropped from 4th for the most of my career. Another unique feature about ovarian cancer is that we have more and more women with ovarian cancer. 200,000 women estimated living in the United States with ovarian cancer and 600,000 worldwide. Obviously, if the incidence is dropping and more women have ovarian cancer, it's because we have better survival. The incidence has gone down 29% over the time period from 1985 to 2014, and mortality has dropped by 1/3 since 1975 to 2015. Improvements in outcome are thought largely due to less use of postmenopausal hormone replacement therapy, more use of oral contraceptives since the 60s and 70s, improvements in medical treatments and surgery, of course, and risk reduction surgery in patients who are at risk for ovarian cancer, including patients with BRCA1 and BRCA2 mutations. So we are finally starting to see what we call a bend in the curve on incidence with risk reduction surgeries and strategies to identify patients who may harbor mutations that put them at risk for ovarian cancer. There have been improvements in surgery and the various medical oncology treatments that you'll hear about tonight that have impacted survival. And the link with estrogen is that some of these tumors, a large number of them, do express estrogen receptors, and just like breast cancer and uterine cancer may have some component of response with estrogen, and that with less use of postmenopausal hormone replacement therapy, there has theoretically been a drop in postmenopausal ovarian cancer. Birth control pills are known to be protective, that they lower a woman's risk for ovarian cancer by about 1/3 through mechanisms which are not completely understood. But in the premenopausal age, use of birth control pills over 5 years reduces risk for ovarian carcinoma by about 20 to 30%. Next slide. One statistic that really hasn't changed despite our overall improvement in survival is the fact that 2/3 or to 3/4 of women present with advanced stage. And once a patient has ovarian cancer, approximately 80% of those patients will relapse, even though they're put into a clinical remission, defined as a normalization of physical exam, CT scan, and CA-125. And the reason that so many women present with advanced stage is that we don't have an early detection mechanism for ovarian cancer. We do not have a pap smear as we do in cervix cancer, or a mammogram as we do in breast cancer, to detect stage 1 patients. Only about 10 to 15% of ovarian cancers are diagnosed in stage 1, confined to the ovary when they're most curable. And there are many active areas of research ongoing to come up with an annual or biannual test that could be done in a cost-effective manner to detect early ovarian cancer including surveying the blood for circulating free tumor cell DNA or circulating tumor cells or a variety of other markers. But these are all in active research, and none have been really shown yet to be effective as a screening tool, including ultrasound or the serum CA-125. Outside of perhaps patients who are extraordinarily high risk with BRCA, we might be able to detect those cases earlier, but the majority of patients with BRCA mutations undergo risk reduction surgery as a strategy, a more effective strategy to reduce mortality from ovarian cancer. Next slide. So I wanted to just briefly cover a few topics in the short time we have about diagnosis and treatment, and just give you the landscape, and our other two speakers will dig into more details. The mainstay of ovarian cancer treatment has always been surgery and chemotherapy. There has been a change in that sequence in the past 10 to 15 years, such that approximately half of patients in the United States now, or the Western Europe and the United States, undergo chemotherapy before surgery. We've learned that patients, especially over age 70, with bulky, widespread metastatic disease in the upper abdomen, are very difficult to clear of that disease at their first surgery, and they suffer a greater morbidity or complication profile, and such that it's now been shown that using chemotherapy first to initiate the treatment, reduce the volume of tumor, results in less morbidity with surgery, less organ resection, and more complete resection, and has not negatively affected mortality in that group. In fact, in stage 4 disease involving liver or lung, it has increased survival. Once a patient has undergone surgery and chemotherapy, they typically enter a surveillance time, which would either be watching for recurrence of disease or perhaps continuing maintenance therapies. And we have several new options for maintenance therapy, which will be discussed tonight, to help prolong clinical remission. Remember, about 80% of patients eventually do relapse. But if we can lengthen that remission time, we're improving quality of life, or at least not reducing it, by keeping patients on maintenance therapy and avoiding combination chemotherapies, which of course carry more toxicity with more treatment. Genetic testing has become mainstay in the Western world for patients with ovarian cancer. It is now universally recommended and accepted by all professional organizations that a patient diagnosed with ovarian cancer must be tested for inherited gene mutations, which can affect downstream relatives and parallel relatives, siblings, as far as identifying patients who may be at high risk for not only ovarian cancer but breast cancer, and then affording early testing and/or risk reduction surgery for these patients. Genetic testing also gives us signals for maintenance therapy, which become very important, which you'll hear about later tonight, and is an integral part of the paradigm for determining maintenance therapy, which is usually done during the upfront chemotherapy and surgery, such that you map a plan by the time the patient has completed their chemotherapy. Quality of life and managing effects of treatment is a increasingly important aspect of ovarian cancer care now that so many more women are living with ovarian cancer. We do have long-term consequences and side effects of the therapies that we offer patients. Everyone has heard about the term chemo brain, which is a mild, oftentimes rather temporary loss of cognitive function, but it can be long-lasting for patients, and can be helped with active management. Loss of sensation in the fingers and toes, called neuropathy, is a consequence of platinum and Taxol-based therapies. which can be quite devastating for some patients, and really for some patients has very limited treatments available, but we do have things that can palliate those symptoms. Those are areas that we need more active research in about how to prevent some of the chronic side effects of chemotherapy. We're actually pretty skilled and have a lot of armamentarium for the acute side effects, but we need a little more research, I think, in these areas, and hopefully we can come up with better treatments for some of the long-lasting effects of therapy. And that brings us to research and clinical trials. While we've improved progression-free survival and overall survival, and we have more women living with ovarian cancer, there's still a big gap, and we have a long ways to go to improve the overall cure rate. There are many active areas of research in ovarian cancer. However, new drug development in the past decade has plateaued, and more of the active research in solid tumor oncology now is working with immunotherapy, drugs or products to affect the immune system and try to get more innate action from the immune system on the cancer. Unfortunately, ovarian cancer has been a rather stealthy cancer that avoids the immune system, but we have several bright spots of research that I think will bear fruit in the next decade to help combine our standard cytotoxic therapies with immunotherapies that can hopefully result in better cure. The molecular profiling of ovarian cancer is shown to the right, and I really just threw the cartoon up to tell you that when we speak about ovarian cancer, we're really speaking about dozens of disease, and every one of those categories has subcategories which aren't shown in this pie wheel. And we are rapidly approaching a time that every patient's genome will be profiled, and we will be able to target areas of weakness in the tumor and better treat ovarian cancer rather than approach ovarian cancer as a one-size-fits-all. And I have no doubts in the next 10 years that this treatment paradigm will continue to expand with more drug development targeted at specific defects in the genome of the cancer. Next slide. Wanted to just close with a word about patient resources. SGO.org is an excellent online source with a survival toolkit for patients with gynecologic cancers. I would invite you to look at SGO.org. The Ovarian Cancer Research Alliance has a site, okrahope.org, with patient resources for general information, support groups, and financial assistance. The American Cancer Society, of course, in almost every community has a chapter with resources, and most hospitals and cancer centers have local support groups that can be quite helpful. Next slide. I wanted to close by saying it takes a real team to treat ovarian cancer. The team we have at Advent Health, our office, is actually shown to the right, and behind this team are hundreds of people that affect good quality care with ovarian cancer, all the way from intake to anesthesia to the ICU. But just in the office setting alone, it takes dozens of people to process complex care in today's world. Our clinical team on the left includes 4 fellows in training and 4 mid-levels and a PhD. So ovarian cancer, as many cancers, is a very complex disease state that we can only advance through research, innovation, and training. And I would encourage patients to always be taking advantage of the cancer centers in your area. Keep an eye on avenues of research. Visit clinicaltrials.gov. Stay abreast of the advances in ovarian cancer, and look for the next treatment paradigm, because we've seen it over and over again in our patients that when you get a good response to therapy, even if you relapse, we have many other treatment options available that can keep patients alive and well with good quality of life for many, many years, just by staying abreast of what's happening in this field. So I think that is probably my last slide. I would like to now turn this program over to Dr. Natalie Mckenzie, who I introduced as a partner of mine at the Advent Health Cancer Institute in Orlando, Florida, and director of our fellowship training program. Natalie?
Good evening, everyone, and thank you, Dr. Holloway, for the introduction. I'm going to finish this talk by discussing the 10 Commandments of Cancer Survivorship. Prior to that, I'm going to briefly go over some of what Dr. Holloway has previously mentioned, quickly talk about treatment and clinical trials, and then move on to real-life issues that patients living with ovarian cancer face on a daily basis. Thank you. Next. So with regards to ovarian cancer, you'll see that it may not be the most common cancer in the however, it is the most lethal. Next. The overall 5-year survival rate for stage 3-4, which is when cancers are typically diagnosed, is about 45%. There are no accepted effective screening strategies, as Dr. Holloway previously mentioned, and the symptoms are quite vague, which include bloating, early satiety, urinary frequency, increase in waist size, GI upset. All of these symptoms are quite vague. Usually patients can start off sometimes with gastroenterologists before they make their way to GYN oncologists, unfortunately, further delaying diagnosis. It is without a doubt and has been published in the literature that women with ovarian masses who have been identified preoperatively as having a significant risk for ovarian cancer should be given the option of having their surgery performed by a GYN oncologist. This saves lives and significantly improves outcomes. Next. In fact, there are numerous studies, and 3 of them are highlighted here, but there are numerous studies that show that when patients are treated by GYN oncologists, especially those at high volume centers, outcomes are significantly improved. Next. Family history is incredibly important as well. We want to better understand the family history of a patient with an adnexal mass and or ovarian cancer to better understand both the patient's potential risk for other malignancies as well as the genetic testing of family members, which again may allow us to offer risk-reducing surgeries. Next. You'll see here in this slide, as Dr. Holloway showed earlier, that there are different hereditary components. Brca 1s and the Brca 2s certainly make up the largest component of known hereditary cancers, but there are others, including the RAD51C, RAD50, BRIP1s, BARD, PALB2, STK11P53, CHEK2 is a new player in the Lynch syndromes. Hereditary non-polyposis colorectal syndrome is associated with breast, colorectal, and ovarian cancer being 10%. Next. So why does genetic testing matter? So previously you heard that we have a new paradigm whereby all ovarian cancer patients are tested genetically, either germline and or somatic. And this is very important because it's not just to identify the possibility of other malignancies and for the family members, but it's also a prognostic marker, and it also allows for targeted treatment. So here you have a situation whereby a woman who is tested at the beginning, at diagnosis of ovarian cancer, has the opportunity to potentially benefit from different treatment strategies. For example, we know that the Brcas are more likely to be platinum sensitive. We also know that the Brca positive patients may have an enhanced or improved response to intraperitoneal chemotherapy. So that knowledge helps the GYN oncologist better care for the patient at time of diagnosis with regards to surgery, with regards to choice of chemotherapy, as well as maintenance therapy. Next. So we're going to talk a little bit about CA125. CA125 is a transmembrane glycoprotein that's produced by the pericardium, the pleura, the peritoneum, epithelium, Mullerian, fallopian tube, ovarian, endometrial, endocervical epithelium. It's elevated in about 80 to 85% of advanced epithelial ovarian cancers. Not all ovarian cancers are going to have an elevated CA125. There is a roughly 15% false negative rate. And in fact, stage 1 ovarian cancers, only 50% of them are going to be elevated. And it's not commonly elevated with non-epithelial ovarian cancers like the other more rare ovarian cancers that Dr. Holloway mentioned earlier. It has low specificity, and particularly in premenopausal women. And next. In fact, this is a long list of other entities that may cause an elevation in CA125. Yet, until we get to do a better job with circulating tumor DNA and other modalities, CA125 is still a great tumor marker when initially elevated to monitor the course of treatment for a patient with ovarian cancer. However, with regards to diagnosing an ovarian cancer, it does fall short sometimes. Next. Treating advanced stage epithelial ovarian cancer is nowadays predominantly through two different routes. Either we start with neoadjuvant chemotherapy, whereby patients will receive a platinum-based chemotherapeutic regimen, approximately 3 to 4 cycles, after which the goal is cytoreductive surgery, optimal tumor debulking to no gross residual disease. It's very important that when the GYN oncologist goes in after 3-4 cycles of chemotherapy, their goal really is to leave no tumor behind. After which, 3 to 4 more cycles of platinum-based chemotherapy. The platinum and paclitaxel backbone is the standard backbone regimen, whereby other chemotherapeutic drugs may be added, such as bevacizumab, aka Avastin, and in clinical trials, perhaps immunotherapy or other new investigational drugs, followed by monitoring or maintenance therapy. For patients who on radiologic investigation and or laparoscopic investigation appear to have disease burden that allows for primary surgery, that allows for upfront complete resection of disease burden, those patients indeed are offered primary surgery, and then chemotherapy ensues afterwards, typically 6 cycles. However, additional cycles may be necessary depending on the individual case Again, this is either followed by monitoring or more likely these days with maintenance therapy, typically with PARP inhibitors and or bevacizumab. Next. So patients are doing better. There are better surgeries, better drugs, better surgical techniques, targeted agents such as PD-L1 inhibitors, immunotherapy, PARP inhibitors, tyrosine kinase inhibitors, and TTF Field is a clinical trial that we have opened at Advent Health Cancer Institute, whereby patients are either randomized to weekly paclitaxel and or TT Fields. TT Fields is an apparatus that delivers low dose, low intensity electric fields to the tumor site. This was initially investigated in glioblastomas and some brain tumors, and is now FDA approved for such, and is now being explored for ovarian tumors. And basically what occurs here is that the device delivers the low intensity electronic fields, which then cause electronically charged cellular components within tumor cells to change their location. And the location is changed within the dividing cell, thereby disrupting their normal function and ultimately leading to cell death. And they have found that TT Field in combination with weekly paclitaxel further improves cell death. And this is particularly exciting for us for platinum-resistant ovarian cancer. Platinum-resistant ovarian cancer tends to have an extremely poor prognosis as compared to the more platinum-sensitive ovarian cancers. They have better treatment options. PARP inhibitors are more likely to be efficacious in that regard. So this is just one example where clinical trials really have the potential to make a huge difference. Next. But patients, as a result, patients are living longer. And so I want to focus the rest of the slide deck to what occurs with the patient who is alive, who's trying to live her life, and the concerns that most ovarian cancer patients face while living with cancer. Next. We'll start with fear of recurrence. Fear of recurrence has been classified, and through investigational studies and interviewing techniques is associated with lower optimism, lower quality of life, lower levels of education, race, physical symptoms, family stressors, absence of or few significant others. But there's fear of recurrence that can be normal. There's also fear of recurrence that can be pathologic and must be addressed with a mental health counselor. And so in diagnosing pathologic fear of recurrence, there are certain recurring themes that can be elicited through interview. These include death-related thoughts, feeling alone, believing that cancer will return, experiencing uncertainty, having cancer-related thoughts and imagery that were difficult to control, daily and recurrent thoughts, and experiencing significant distress. So researchers from the Canadian Association of Psychosocial Oncology have put together some recurring themes and into a screening form that allows for this diagnosis. The role that the clinician plays is to better understand where fear of recurrence may be significantly affecting quality of life, and thereby referring the patient to the appropriate specialist. Next. Grief is another one of the other top 10 concerns of ovarian cancer survivors and ovarian cancer patients on treatment. But it's important that when dealing with grief, that patients allow themselves to acknowledge the grief. And specialists and experts recommend the following: experiencing your own grief as unique, talking to yourself about your grief, feeling a multitude of emotions is okay, and allow yourself to realize that this is going to occur. Understand that experiencing grief may come as attacks, and be prepared for that. Be tolerant of your physical and emotional limits. Makes use of rituals whereby you learn to deal with your grief in a ritualistic way. Embracing your spirituality, which has proved to be helpful for patients in the past. Searching for meaning and purpose in life. Treasuring past memories, and moving towards your grief and healing. Next. Depression and anxiety is a very common theme. 20% of patients actually experience clinical depression or severe generalized anxiety, and only 40% of patients accept professional help. This affects the cancer and non-cancer mortality. And the American Psychosocial Oncology Society and the NCCN network both recommend routine survey of symptoms. This is typically done by medical assistants, usually in oncology practice, where short surveys are used to better understand if a patient is experiencing depression, anxiety, and then the office has the means with which to refer the patient to appropriate specialists. These specialists may employ pharmacologic therapy, cognitive behavioral therapy, as well as online or app-based interventions. They may recommend self-guided books and group-based psychological therapy. Next. Body image, self-esteem, and intimacy are issues commonly faced by many cancer patients, including our ovarian cancer patients who either lose their reproductive organs and or have functional limitations with regards to these organs. We know that surgery and or chemotherapy can result in temporary or permanent physical changes, either linked to the cancer or the cancer treatment. Hair loss, scars, loss of reproductive organs, weakness, infertility, sexual dysfunction, and or limitations are all reported by patients. However, with mindset shifts, creativity, and redefining life, patients do have hope, and there are many resources available to patients, both at your institution as well as outside of your institution. Certainly addressing some of these concerns with your physician, as well as other specialists such as physical therapy, pelvic floor rehabilitation specialists, mental health counselors, sex therapists, handbooks such as those provided by the American Cancer Society or cancer.org. And there are videos also available. One that I highly recommend is triagecancer.org, particularly useful, educational, with real world, real life solutions. Next. Patients often find that they have an enhanced need for spirituality while dealing with cancer, and experts who have explored this field have really defined it in terms of 4 spiritual themes: one of connection, social support, and normalization of behavior, the theme seeking peace, inner peace, forgiveness, and hope, meaning and purpose of reality, reliance on self and meaning of life, and transcendence, strengthening spiritual belief, communication with a deity and or prayer. Spirituality and quality of life, huge difference here. Patients who are able to harness their spirituality, in fact, do report an increase in quality of life. They specifically report decreased feelings of anxiety, depression, and anger, decreasing feelings of loneliness, decreasing alcohol and drug abuse, lower blood pressure, better control of pain, nausea, and discomfort. Next. Survivor guilt is real, and it can come in different forms. Survivor guilt can come in the form of outliving other cancer patients with whom the patient bonded. Maybe this was a friend that sat in the chemo chair next to you, and she's passed away and you're still alive and you feel the guilt of that. But survivor guilt can also be the guilt of being a burden to family members, friends, and coworkers. And there are definitely ways to mitigate that survivor guilt. So one of the important things to remember is to allow yourself to grieve. Initiate positive remembrance of those lost. Kind reciprocity, meaning if the universe seeks to help you, embrace that help. When friends, family members are trying to help, don't push them away. Accept the help. And when you're able to, a gentle act of kindness or even a simple thank you is enough. Finding stress relievers and seeking groups and professional help are incredibly important. Selecting a surrogate decision maker is important. Identifying values and priorities. Researching and understanding your options, clearly communicating and writing down your goals, and revisiting and modifying as necessary are also very important with regards to identifying future goals. Next. Relationship changes also occur very frequently with cancer survivors, and that may be with a spouse, with children, with parents, or siblings. So 5 tips for addressing these relationship challenges, including enhancing communication, breaking the ice, addressing, better understanding what your emotional needs are and communicating that with a spouse or other family member, establishing roles so that there's no confusion. If you're weaker, you're more tired on chemotherapy, there's less stress in the house when roles are clearly established, asking for help when you need it, and planning, discussing plans for the future. These are the 5 tips associated with mitigating relationship issues. Next. Advanced care planning, the 5 components. Advanced care planning is very important. It involves making decisions about your future care with your health and social workers, and including your physicians. Selecting a surrogate decision maker, identifying values and priorities, research and understanding your options, clearly communicating and writing them down, revisiting and modifying them as necessary. Next. Life and workplace. Unfortunately, some patients do still work while on chemotherapy. They have to. And some patients are very active in their community and in their neighborhoods. And the cancer treatment and cancer itself, it significantly affects your life and your workplace. In fact, 40% of the 14.5 million cancer survivors are working age. So it's important to seek legal advice if you need it, knowing what your employment rights and company policies are, if they exist, and acknowledging that you may have a shift in mindset. You may be inspired to have a career change or life direction. Getting back to normal doesn't always mean getting back to normal after treatment. It's maybe getting back to a new normal and being forgiving of yourself that your normal will be new, and setting expectations and allowing for flexibility in life. Next. The legal and financial impact of cancer is real. In one study, 42% of participants reported a significant financial burden associated with cancer and cancer treatment. Cancer treatments are expensive. Insurance coverage is often inadequate, and compared to individuals without cancer history, cancer survivors have a higher out-of-pocket healthcare costs even years after initial diagnosis. Collectively, these burdens are often referred to as financial toxicity. And so addressing financial toxicity involves many components, including better understanding what the financial toxicity is for the individual patient, informed consent, patient bill of rights, managing health insurance, as well as government benefits, and looking into estate planning. There are many great local resources and law firms that assist with these challenges. Next. So health concerns of cancer survivors include severe fatigue, not being able to meet the daily required metarobic guidelines as provided by the Cancer Institute, the NCCN, and the American Cancer Society. 61% of patients report being overweight and obese, which therefore seeps into other medical problems in life. And 98% of patients agree that a survivorship program of sorts would be beneficial. Next. Which is why at Advent Health, in our practice, we created a lifestyle medicine-based solution to these issues. Next. And the program is based on the 6 pillars of lifestyle medicine, which includes eating a whole food plant-based diet, physical activity, managing stress, forming and maintaining positive relationships, improving quantity and quality of sleep, and avoiding risky substances such as too much alcohol or tobacco intake. Next. The program is an 8-week intensive lifestyle immersion program based on the 6 pillars of lifestyle medicine, and also includes body image and cancer-related sexual issues, cancer-related symptoms, and health literacy. Next. Most of the demonstrations are either a demonstration such as with a cooking demonstration chef in the teaching kitchen, but also includes experiential activities performed by the group along with the physician and the exercise physiologists, such as yoga, strengthening, and band stretching. Next. It appears that 100% of patients who participate in this program find it life-changing and often state that they wish they knew about this at time of diagnosis, to the point where we are now offering this not just to cancer survivors, but to patients who are newly diagnosed if they feel up to the program. It's been a great addition to the resources that we are able to provide to our patients. And we are publishing research data about this experience and find that it is mitigating cancer fatigue, decreasing or mitigating further functional decline for patients who are on multi-line treatment, as well as on those on maintenance therapy. Thank you. So now I'm going to pass the baton to Tim Nguyen from Cleveland Clinic, Florida, who is going to talk a little bit more about systemic treatment for advanced ovarian cancer.
Good evening, everyone. My talk's going to be on treatment for advanced ovarian cancer. Advanced ovarian cancer is pretty much cancer that has a low chance of being cured with surgery alone. Next slide, please. So with cancers, I have a high risk of recurrence after surgery or not able to have surgery because the extent of the cancer. This is where chemotherapy with targeted therapy, which is what we talked about later, is being used. So chemotherapy and targeted therapy used for advanced ovarian cancers done in someone who's newly diagnosed with the cancer or a cancer has recurred after the initial surgery. And as talked to earlier about with Dr. Holloway, that if the cancer is relatively advanced and there's a chance that the person can have a surgery, and the surgery can be made easier by shrinking down the cancer. So just chemotherapy can be given before surgery to decrease the bulk of the cancer in order that the surgery can be done more easier. Or if someone who has a cancer can be operated first, had the operation first, and was found that the cancer is relatively high risk, meaning the cancer has high chances of coming back, and the chemotherapy can be given after the surgery to prevent it from coming back. And chemotherapy can give pretty much in between. Part of it is given before the surgery, and part of it is given after surgery. And also, in those, especially with cancer that can be cured or high risk of it coming back, chemotherapy is given in conjunction with maintenance treatment. This is to prolong the life of the patients and prevent the cancer from getting worse or coming back. Next slide, please. So having an advanced cancer that has a low chance of cure rate, what are the factors that affects patient survival? One is someone's health. If you are a relatively healthy person, you can continue your treatment because treatment itself can cause side effects and decrease your health. And if you are healthy to begin with, you have more strength to continue the treatment and treating the cancer. The other factors affect the survival, how advanced the cancer is, and what symptoms it causes to your body. One of the common problems with ovarian cancer is it grows inside the abdomen where it can block the bowels. It causes a lot of fluid in the abdomen, where someone's like 9 weeks pregnant that they feel uncomfortable and not able to eat because they always feel so bloated and full, or even the fluid can seep up into the lung without difficulty breathing. And occasionally, when say a patient has surgery with a cancer and the cancer comes back and it comes back in a very little bit amount, and patient feels perfectly well, and patient may not necessarily need treatment right away, and this is what an indolent state, versus someone who has the cancer that comes back and within the next few months the cancer explodes and spreads everywhere. These are more aggressive type and history of cancer. The other aspects of how well someone will survive with the cancer is pretty much how sensitive the cancer is to this chemotherapy treatment. Sometimes when a patient gets chemotherapy, the cancer melts away. Other times, the patient gets the chemotherapy and the cancer doesn't do anything, or even rarely the cancer even grows while on chemotherapy. Those are the bed resistance cancer. Similarly, if the cancer has a targeted characteristic to it, where you can use the targeted drugs, which I will talk to you about later, and how well someone can tolerate chemotherapy. If they're able to have very minimal side effects that are manageable, they can continue with treatment in a way to control the cancer, but the very bad side effects like tiredness, fatigue, nausea, numbness sensation, hands and feet, low blood counts, put them at risk of bleeding or infection, or an allergic reaction to chemotherapy, and they can't a limited amount of chemotherapy they can get. Next slide, please. So pretty much key points of treatment: you want to treat the high risk cancer that you know is going to come back, or cancer that you can't get rid of. So you have to find some way to control this cancer, get rid of it as much as possible, so the cancer won't cause harm to the body. And to find a treatment that best shrink away, get rid of the cancer as much as possible, and reuse the treatment again when the cancer comes back or progress. And the other one, if you can't get rid of the cancer, you have to find a way to prevent the cancer from getting worse, and that's the use of maintenance treatment. Maintenance treatment is used because with chemotherapy, there's a lot of side effects, but maintenance treatment is generally mild treatment that causes little permanent side effects, and it can be used for many years, yet control the cancer. Next, please. As alluded to, one of the medications used is bevacizumab, and this is mechanism of action of this drug. You see on the panel A, the tumor grows by having blood supplies to it, and that blood supply gets to the cancer by a substance that the cancer produces called VEGF, VEGF, and this substance recruits blood vessels to it, and blood vessel brings nutrients and oxygen, allows the cancer to grow and allows the cancer to spread. This drug, bevacizumab, in purple, kind of block the substance that the cancer produces to recruit the blood vessels. So it kind of clear away the substance. So there's no signal for the blood vessel to get to the cancer, which makes the cancer less chance of growing. At the same time, there's chemotherapy is going to be around to cure the cancer. Next slide, please. Well, the study that was done to show how if bevacizumab works well with chemotherapy and helping to control the cancer well is one of these trials that use chemotherapy. You see the square boxes on top is the chemotherapy, the platinum, carboplatin, and paclitaxel that's given every 3 weeks, 6 times, versus the bottom patients who gets the same chemotherapy, but this time with bevacizumab that's given along with the chemotherapy and follow as a maintenance treatment after completion of 6 of this combination chemotherapy treatment. And this is again in high-risk cancer patients who have a high risk of the cancer coming back after surgery. Next slide, please. And so this is the how comparing patients who received the bevacizumab and patients who did not. And in the red, the patient who received bevacizumab do better than the patients who didn't receive the bevacizumab. So this is their survival, and this has become the standard of care for patients with advanced cancer to get treatment with the chemotherapy with bevacizumab as a treatment along with chemotherapy and followed by maintenance therapy for the high-risk cancer that can come back. Next slide, please. So the typical course of cancer treatment, starting from the left, the patient's diagnosed with their advanced cancer. Either they get surgery first or they don't get surgery because the cancer is too advanced. And then they get the standard of care chemotherapy treatment, which is the platinum and paclitaxel and bevacizumab, which I mentioned you about. The reason why plus or minus because there are some potential complications with bevacizumab that you can't use if someone who presents with a bowel obstruction, and you can't use bevacizumab in that condition because it can cause the bowel obstruction worse. But it's the case that there's no contraindication for bevacizumab use, patient get this combination chemotherapy. And then after a period of time, the cancer pretty much gets the best response where it shrinks down as much as possible or even completely gone away, and the chemotherapy stops, and you watch closely to see if the cancer either returns or gone away. As Dr. Holloway alluded earlier, that for advanced disease, up to 80% of the cancer would come back. And what do you do when the cancers come back? And that depends on how sensitive or how responsive the cancer was to the initial chemotherapy that's used. And this is termed called platinum sensitive and platinum resistant. Because platinum is one of the important drugs that seems to be most active for ovarian cancer. Next slide, please. So this one just follow the blue bar actually. If someone who is considered platinum sensitive, meaning that they received the first combination chemotherapy and the cancer goes away completely and hasn't come back for over 18 months, so like 18 months of you doing CT scan, you see how the cancer finally came back after a year and a half. These people tend to do well because you can use the same chemotherapy again and repeat what's been working, versus patients on the left side of the graph shows that if they say they get the same chemotherapy and you do a scan in 3 months and say, oh, there's new cancer that pops up, and this is the cancer that's very resistant, and using the same chemotherapy will not work. Next slide. So with patients who has the cancer that comes back, and if there are considered platinum sensitive, meaning that at least 6 months that the cancer comes back, and you can reuse the same chemotherapy again. And in this particular study shows that you use, you use the same chemotherapy again with the addition of bevacizumab. It shows that reusing the same chemotherapy and bevacizumab allows patients to live longer if you don't use, compared to not using bevacizumab. So the middle panel, the bevacizumab treatment is the curve on the top, which means that people live longer, less chance of the cancer progressing. Next slide, please. This is a patient who, the unfortunate insensitive or cancer does not control on the platinum medication, that the cancer came back relatively short period of time after finishing the chemotherapy. So in these patients, using the same chemotherapy again would not work. Use a different chemotherapy, and this in case you use just one chemotherapy treatment. But using bevacizumab again seems to help with a different chemotherapy regimen. And you see here in the top curve, again, this patient who received bevacizumab with a different chemotherapy, and the bottom curve is the one that patient just get the different chemotherapy without bevacizumab. And each of those graphs shows that bevacizumab helped to improve patient survival. Next slide. And now there's a relatively big breakthrough in ovarian cancer is the use of maintenance treatment, not with bevacizumab, but with a PARP inhibitor. In cancer, cancer are very rapidly dividing, especially those aggressive growing cancer. And cancer often have DNA thus being damaged because the nature of how cancer are rapidly dividing, it makes a lot of mistakes, and the DNA doesn't divide well. There's some damage to the DNA. And cancer have a way to repair this cancer. If the DNA is not repaired, cancer will die. Some of those mechanisms of the cancer repairs the DNA is called homologous recombination protein, including the PARP proteins and Brca, which help to repair the DNA. So if the cancer cells are deficient in this protein, including the Brca, which the Brca mutation, the cancer are more prone to having the DNA damage. Using a PARP inhibitor, which inhibits the mechanism of the cancer repair DNA. So it's already, if the cancer is already prone to having DNA damage, and having a drug that further enhances the inability of the cancer cells to repair the DNA, then cancers are more susceptible to death. Next slide, please. So there's just a diagram on the top where the cancer, beginning with a little dot, meaning this cancer DNA is broken because it's the nature of how cancer grows, and the cancer repairs the DNA, and that's why you have normal DNA, double DNA, where the cancer divides. On the bottom there is a medication that will inhibit the way how cancer repairs DNA, and this will allows the damaged DNA to persist, and more damaged DNA persists in cancer, the cells are prone to dying. Next slide. Sorry, go back one slide. So this treatment, where again, the same, that patients who are high risk, have high risk cancer, gets the standard platinum chemotherapy with the paclitaxel. And after 6 rounds of this chemotherapy, instead of going bevacizumab like they did before, these patients with the mutation, the inability to repair the damaged DNA, then go on to get one of these PARP inhibitors, versus no treatment, means just observe. And patient gets this PARP inhibitor for at least 2 years. If there's no signs of cancer, would rescan or continue until the side effects of the treatment start working. Next slide. So here in this graph, on the top graph, the green graph, is patients who received the PARP inhibitor after they finished the chemotherapy, versus the bottom graph, where the patients didn't get anything after they finished the chemotherapy. And you see that there's a lot of more patients had cancer recurrence if they didn't get the PARP inhibitor. And even at the 4-year mark, that more than 50% of the patients who had the PARP inhibitor didn't have the cancer come back. Next slide, please. And this is another way of representing a graph versus people who get the PARP inhibitor maintenance versus those without the PARP inhibitor. And you go all the way to the right at the 48 months. That's more than 4 years, or 4 years, that more than half of the patients with the PARP inhibitor survives without the cancer getting worse, or without the cancer returning if the cancer completely goes away, versus only 11% of the patients who didn't get any PARP inhibitor after their chemotherapy treatment. Next slide. Unfortunately, PARP inhibitor does have some side effects with it, and that's why you don't give it to everyone unless they will benefit from it, meaning that they have DNA mutation repair mechanism that the PARP inhibitor seems to work best. Some of the side effects occurs the nausea, being tired, some vomiting, some low blood counts, including anemia, some diarrhea. But with this medication, and people have been on for 2 years and they'll study even longer, that most of the side effects tends to occur within the first few months. And afterwards, the body somewhat get used to it, or there's dose adjustment where you lower the dose, where you allow patients to manage their side effects and they still able to maintain the effectiveness of the medication. Next slide. That's why it's important to identify individuals that will benefit from PARP inhibitor. It's been estimated that up to 50% of patients with advanced ovarian cancer can benefit from this PARP inhibitor. And this test is done on the gene, somebody's gene, or on the cancer's gene, because the cancer itself can be different, have manifested different genes from your own genes, and this is called somatic mutation. And up to 50% of the patients can either have their genes inherently has the mutation, or the cancer itself develop the mutation on its own. And other cases, these patients would benefit well from the PARP inhibitor medication. Next slide. So summary, this is my last slide. For advanced cancer, standard first line, someone which is diagnosed with a newly diagnosed cancer comes back, you treat it with the platinum chemotherapy, which is the most effective chemotherapy for ovarian cancer. And you add bevacizumab, which makes the cancer work much better. And when cancer comes back, you reuse the same chemotherapy that works, especially those that is controlled for at least 6 months on the initial chemotherapy. And since most of these patients are not, that can come back and not cure, you want to maintain control of the disease as long as possible. And hopefully you can maintain the quality of life at the same time, and using maintenance treatment would achieve that, because it doesn't involve the chemotherapy to give you the side effects, and maintenance chemotherapy tends to be quite manageable, where people can get on with their normal lives. And for those who have DNA deficient protein repairs, the use of PARP inhibitor is very important in helping to control the cancer further. I think that's my last slide. Thank you.
Thank you, Dr. Nguyen. If Dr. Nguyen's presentation brought up any questions, I encourage you to type them into the questions box. We'll be collecting those during the talk and then address those fairly soon. Next, we'd like to hear from Marlene Morales, who will turn on her webcam and discuss patient assistance programs and caring for the caregiver.
Hi, my name is Marlene Morales, and I am a licensed clinical social worker at Sylvester Comprehensive Cancer Center. And I work primarily with the gynecology oncology patients. Most of my patients are diagnosed with ovarian cancer. My job entails many things. I help patients with advanced directives. I help them navigate through patient assistance when insurance doesn't cover their specialty medications. I help patients with transportation to treatment, and basically address any barriers that come up after you obtain the diagnosis of cancer and you're going through treatment. I guess the most simple way to explain the job is basically go through the challenges, the burdens, and the obstacles with the patients and their caregivers upon getting diagnosed. What you're going to see in front of you is a flyer that I created for our patients at Sylvester. It's an ovarian cancer resource flyer. It has many resources. It doesn't have all the resources that I use all the time, but I've divided it into some categories for you so that you can understand. I won't go through all of them, but I will go over some of the assistance programs that are open financially right now that you may want to apply for. So this flyer is divided into financial assistance programs, patient assistance, miscellaneous, transportation, lodging, and housing. Some of the patient assistance and financial assistance information that you see, some of the information overlaps because some of the programs don't only provide assistance for the medications, but they also provide support for the patients and for their family members. So what you're like, for example, when we look at on the patient assistance program on the right, you're going to see the Patient Advocate Foundation Copay Relief Fund, and you're going to see the PAN Foundation and Cancer Care. These three websites are disease-based, and you can find funds that are open under ovarian cancer or maybe available under the patient's age group, maybe the type of cancer that they have, the type of ovarian cancer that they have, to assist their families with household bills, medical bills. But they also assist with providing support to the patient and to the caregiver as they offer support groups, and they help you link to members in the community that are also struggling through the same issues. One of the things that you're going to see as well is transportation. Transportation is a big issue that I come across with the ovarian cancer patients, is getting to treatment. And getting to treatment could become an obstacle when you don't have a family member or a friend or somebody in your peer network that's available to help you to get to treatment, especially if you're feeling fatigued or feeling nauseous or having symptoms from undergoing the chemotherapy treatments for ovarian cancer. So what you need to know is that sometimes there's no cross-county transportation for patients. So most of the time, patients can lean on the American Cancer Society Road to Recovery program. This program was available prior to COVID, but unfortunately is closed down, which has it's caused a barrier for patients at this time when it comes to getting to treatment. So I get these calls where it's like, what do I do? How can I get to the treatment? And I guess sometimes there are transportation services, specialty services available in the county. The three main counties that I work with in Florida are Miami-Dade, Broward, and Palm Beach. And those three county services, specialized services, are available on this flyer. If you need to reach out, obtain an application, or if you have questions, you can ask me in the chat later. Some things that a patient might not know in reference to their insurance when it comes to transportation is that sometimes your insurance does have transportation available to you. For example, if you for any chance have Medicaid, whether it's primary or secondary, if you have an HMO Medicaid, for example, such as Sunshine, Prestige, Molina, Humana, United Healthcare, a lot of these Medicaid insurance also provide transportations to their patients, and they will take you to treatment. So that's something to look into if you haven't spoken to a social worker or anybody at your center for cancer support services. That's something to call your insurance, educate yourself, and learn about it, because it could be something that could be easily fixed, and it's something that you could already have. Some of the foundations that I wanted to talk about that are open right now, if somebody is in need of paying household bills such as utilities, electricity, cable, water, is the Women Cancer Fund. The Women Cancer Fund assists patients, women that are diagnosed with cancer, and basically you would fill out an application with your social worker, your doctor, your nurse practitioner, or somebody on the team, you would turn in a copy of your bill that you're needing assistance with at the beginning of the month, and then the Women Cancer Fund reviews your application and then provides you with approximately $250 to pay for your utilities that you're unable to afford that month, depending on your situation. One fund that I know is open right now is the Patient Advocate Foundation Copay Relief Fund. They have a fund that's specific to COVID-19. I know that COVID-19 has been a struggle for patients, for families, whether it's for work. This particular fund provides up to, I think it's $3,000 to $4,000 that they can assist with hospital bills or medical bills that are outstanding that you're unable to afford as you're going through treatment. And this could definitely take away a stressor that you could be going through. It is open right now. I did check this morning. I check daily. And it is available. I know that the one that's specific for ovarian cancer on the Patient Advocate Foundation Copay Relief Fund is not open, but you can check daily as well to see if there's something that applies to you. Maybe there's a different diagnosis that could be helpful. The PAN Foundation also has disease funds that are available to the ovarian cancer patients. I'm not sure if that one is open right now. It changes by the hour, daily or weekly, but there is something available for the patients. They also have, I don't know if you want to Google it or if you want to look on their actual website, the PAN Foundation and the Patient Advocate, they do have a fund finder. So the fund finder is where you can include your age, your diagnosis, where you live, and they can find resources that are available to you in your location and tell you, what's open if you don't have a social worker available to you. In addition to providing financial assistance, because I'm not going to go over everything that's on this flyer, these two organizations, the Patient Advocate Foundation, the PAN Foundation, Cancer Care, the Ovarian Cancer Research Alliance, also provides emotional support to our patients diagnosed with ovarian cancer and their families. These websites provide support groups for caregivers. They provide support groups, virtual support groups for the ovarian cancer patients. It is, some of them are population-based, where it could be maybe young women that are struggling or have a diagnosis of ovarian cancer that are available to them as well. Something that they also have, I believe it's on Cancer Care, is parents that have children and they don't know how to talk to their children about cancer. There are resources available as well where you can talk to family members, what to say, what to do, and support groups available for the children and the adolescents that have parents that are diagnosed with cancer. So that's something to look into if you're interested, if you're looking for additional support. I know that it's important if you are struggling through depression or anxiety or any worries or fears because of cancer, that those issues get addressed. And sometimes it is easy to talk to a social worker, a mental health specialist, a psychiatrist, or a psychologist, and they can help by providing medication and therapy. But sometimes these support groups are important because you get to talk to individuals that are actually going through what you're going through, and it's important to connect with those individuals, and it makes things easier. One of the organizations that Sylvester works with, and I'm constantly always referring patients to, is the Woman to Woman program from the Ovarian Cancer Research Alliance. This is a mentorship program that we have at Sylvester, but it's also a national program available to patients where you get matched with somebody with your diagnosis, a similar age group that has gone through a similar issue, has been mentored and educated on how to mentor the volunteer or the mentee. And it's basically a source of support, somebody you can talk to, somebody you can reach out to when you're feeling down, or somebody that you want to understand, or you get to talk about, oh my God, I took olaparib, or I was on Zejula and I felt this way. So it's sometimes easier to talk to other people that are going through similar issues. When it comes to caregivers, and we can go to the next flyer. This is just a short flyer of resources, of websites to look into if you're looking for a support group or any additional support for caregivers. It's just as hard to be diagnosed with cancer than to go through that, going through cancer with your family member or with the person that you care about. You have to also take care of yourself. I know that sometimes patients suffer and you want to be there for them and you want to give them your all, but it's important to communicate, take care of yourself, know when to ask for help, and know that you can't do things alone. That's why there are social workers available, there are psychologists available, there are mental health specialists, psychiatrists available that are here to help you. There are support groups. You are not alone. Make sure to always keep in mind to do your own thing as well. Like, just don't only focus on the patient, but taking care of your mental health is very important. You want to give your very best and be at your best in order to help your loved one. One of the best websites, if you haven't retained anything that I've said today during this presentation, is Worst Case Scenario. You have the American Cancer Society, that is your database. When it comes to medications, you're looking for, hypothetically speaking, an emotional support animal. They will tell you what you need. They will tell you what's available in your area, what's open, what's not open. They can even locate you with a social worker, a specialist, somebody that can help you navigate through having cancer. I hope that this helps, and if there's any questions or anything I can do to help, please feel free to reach out to me. My information is available on both flyers. I encourage you to look through these flyers, and I hope you enjoyed this. Thank you so much.
Thank you very much, Marlene, for highlighting these valuable resources. Next slide. Cancer affects each population differently, and minority groups in the United States bear a greater burden for many cancers. The Florida Society of Clinical Oncology is actively fighting cancer care disparities on many fronts. On your cancer journey, you can do your part by making sure you just ask. Help us narrow the gap. To learn more about cancer disparities in ovarian cancer, please download the Disparities in Ovarian Cancer slide packet and Minority Cancer Awareness handout located in the handouts drop-down box at your GoToWebinar panel. Thank you. Q&A slide. We will now move on to our Q&A portion of the webinar. So panelists, go ahead and turn on your webcams. I'll read questions and then ask our panelists to answer a question or portion of the question. We'll continue to answer questions for the next 10 to 15 minutes and then move on to the final portion of the webinar. So let me look at the questions here. Can our panelists turn on their webcams? There we go. So I'll have each of you answer these questions. Dr. Mckenzie and Dr. Wen, here's a question that came in. What are some of the clinical trials that interest you most at the moment? Dr. Wen?
Yeah, so the clinical of great needs right now is treating those patients who are considered platinum resistant patients, the patients who get the initial platinum chemotherapy and then recurs back within 3 months to within 6 months after they finish the treatment. Those are the poor risk patients who will likely have cancer that's very difficult to control. So the clinical trials we're going to do is try to find drugs that will help this patient to have the cancer more sensitive to further chemotherapy treatments.
Dr. Mckenzie, any particular trials you're interested in?
If you can hear me, I'm particularly interested in trials using PARP inhibitors or immuno-oncology such as pembrolizumab in the upfront setting, I think that there's going to be an opportunity there. I am also interested in the platinum-resistant crowd. They're a tougher to treat crowd, and whether it's an opportunity to treat with novel strategies such as the low intensity electric field device in combination with weekly paclitaxel like we have at Advent Health, and a few others. And Dr. Holloway, you are PI for some of these trials. Would you care to mention one or two of them?
I think in ovary we have two upfront treatment trials that are very exciting using immunotherapy constructs with chemotherapy. One is using an antibody complex, origovimab, with carboplatin Taxol. It's a prospective randomized study that was shown in a phase 2 trial to be quite active. And this is a confirmatory phase 3 multi-institution trial. But in this phase 2 trial, it showed significant improvements, not only in PFS, but OS. Theoretically, the antibody tagging ovarian cancer cells and making them more immunogenic for the innate T cell response to affect cell kill with the chemotherapy. The other very interesting trial we have involves placing an intraperitoneal construct that actually inserts DNA into the cancer cell targeted to produce interferon on the cell surface of the cancer cell, and this also attracts T cell response. As I mentioned in the introduction, the ovarian cancer is a very stealthy cancer and is able to evade the immune system. So these are two phase 3 clinical trials. These are randomized. Some patients get the immunotherapy construct, some don't, but everybody gets at least standard of care carboplatin Taxol. So it's not a terribly risky trial from that standpoint, and gives you some chance for getting novel immunotherapy with the chemotherapy. So next part of this question, here's an interesting one that you could, one or two of you could address. Are there any ovarian cancer treatments that prevent us from safely getting COVID-19 vaccine? Do you have any thoughts on that, Dr. Nguyen?
Chemotherapy, I mean, the problem is, if anything, no chemotherapy. I mean, not getting chemotherapy, that would be the best way to not getting COVID vaccine, not getting the COVID infection, because chemotherapy tends to suppress your immune system, and having infected with a COVID infection will make you more sicker. So getting the COVID vaccine is important, especially for patients who are on chemotherapy treatment.
So in other words, there's no reason not to take the COVID vaccine, even though you're currently on chemotherapy treatments.
Yeah, correct. So generally, we can do the chemo. We can take a blood test to make sure that the immune system is in adequate shape before they get the COVID vaccine. So we tend to have patients off for a week before the chemotherapy treatment or after the chemotherapy treatment, and have a blood test to say, look, the immune system is in good shape, so they can go ahead and get the vaccine.
Here's one for you, Dr. Mckenzie. To what extent is
Hello?
fear of recurrence a norm? Is it normal, and when does it become a mental health concern?
Fear of recurrence is normal. It's normal for every cancer survivor on the planet. I have yet to meet a cancer patient and or cancer survivor, whether 5 years out or 20 years out, that doesn't experience fear of recurrence from time to time. When fear of recurrence becomes all-consuming, when there's perseveration, when it's associated with depression or anxiety significantly affecting quality of life, then it becomes pathologic.
What would you recommend a patient who's fearing that this is impacting their quality of life? What should they do first?
Well, the easiest access is your oncology office. whether it's the nurse practitioner or the physician themselves. Some oncology offices have chemo nurses that are available to you, triage nurses. You want to get yourself to a mental health counselor as soon as you can. Sometimes there are psychologists or behavioral counselors that are also available. Some patients have heightened anxiety and or clinical depression that would benefit from behavioral therapy and or from pharmaceutical agents.
I've got a question here for Marlene. How can patients or their physicians acquire the 2 Sylvester Cancer resource lists that you have shown us? Will this be posted on Flasco website, or how can they access these resource lists?
I believe that this presentation and the flyers will be available since it's being recorded on their website. If not, if you want these resources and it's not available on the website, my information is on the flyer. You can reach out to me either by telephone or by email, and I'm more than happy to share these resources with you.
Thank you. Dr. Mckenzie, at what age should the younger women in my family be tested for BRCA mutations?
Typically, geneticists recommend age 21 or older. They pause with patients or women that are younger than age 21, mostly because the adolescents have a tougher time dealing with this type of news when they're not at an age when necessarily it's indicated to begin screening and or intervention. Granted, there are some rarer cases, but by and large, our genetic colleagues usually recommend age 21 and above.
Here's one for Dr. Wen. Dr. Wen, how do you decide whether a patient should take maintenance therapy, and how do you decide which maintenance therapy they should take? 2-part question.
Yeah, am I muted? Yeah, so with maintenance therapies done for patients with high-risk cancer, patients who have high-risk cancer, treatment of the cancer coming back after surgery. So these are the patients who have cancer. When they have the surgery, they see that there's a lot of cancer that can't be removed, especially cancer that's larger than 1 centimeter in the abdomen that can't be removed. Then you know that once you have still cancer remaining after the surgery, it's going to come back. Or patients who present with high burden cancer that in the abdomen where it created fluid in the abdomen and fluid in the lung. These are considered high risk cancer patients that the cancer will likely comes back quickly after they finish their standard chemotherapy. And these are the patients that you want to use the maintenance treatment to prevent it from coming back as long as possible.
Dr. Mckenzie, I'll
I'd
have
also
you.
like to add.
Yeah. Go ahead.
Thank you. I'd also like to add that in considering choice of maintenance therapy, I look at multiple factors, including how the patient has responded to frontline adjuvant treatment, if they experience any toxicities, what toxicities, but then also genetic testing, somatic testing, and molecular profiling also become increasingly important this day and age with regards to maintenance choice. For example, we know from recent trial data that HRD confers a potential advantage to olaparib and bevacizumab for patients who used bevacizumab, especially for those who use bevacizumab as part of their adjuvant treatment. We know that there's an indication for niraparib regardless of genetic status. And then, of course, we know that there is based on SOLO-1 data, that there is the indication for the Brca mutated patients who are platinum sensitive and have had a great response to PARP frontline. There's also indications for recurrent platinum-sensitive recurrent setting. So we have both upfront, first line and second line indications for PARP inhibitor use, and genetic testing, HRD status are becoming increasingly important to guide decision making for GYN oncologists and medical oncologists alike.
Here's a question that I'll address then and ask each of you to comment on further as you see fit. Is there research focusing on developing ways for early detection of ovarian cancer? There actually is research ongoing in several areas. We have participated in a trial in the past, the results of which are still pending, and I have not seen them, but it was actually a trial for patients with a pelvic mass, and we submitted cervical smear for analysis looking for cell-free DNA as a potential test to detect the early changes in the fallopian tube that result in ovarian cancer. And again, we have not seen the analysis on this data, but this trial was headed out of the University of South Alabama in Mobile. And hopefully in the coming year or two, we'll see some results from that trial. There's another ongoing study that we're participating in looking at a blood test, intravenous analysis of DNA fragments to try to predict early onset ovarian cancer. In order for a screening test to be effective, you have to detect it in stage 1 disease when it's most curable. And that's really been the limiting factor on our current technologies, that we can sometimes predict cancers a bit earlier with ultrasound and CA125 screening, but it hasn't really resulted in a reduction in mortality, because oftentimes when we detect it, it's already beyond stage 1. So those technologies have had limitations. So any other knowledge from either Dr. Nguyen or Dr. Mckenzie about any other ongoing detection trials?
Yeah, I agree with the liquid biopsy. That seems to be the wave of the future, which is the least invasive, least exposed to radiation, where you can detect an early cancer through the blood test, that you can detect this abnormal mutated DNA that the cancer released into the bloodstream. You know, still needs to be worked out about its sensitivity and specificity, but right now there's a lot of work has been done into it, and hopefully something will pan out.
I think the other thing that is, speaking from, talking to patients over the years, patients have a hard time accepting or understanding that we have to be cautious with screening tools, because even using CA125 and ultrasound, especially if you look into this data on screening, it results in a large volume of surgery, a large number of women undergoing surgery for masses that turn out not to be cancer. And we know that there's morbidity associated with all surgery. And so unless you're really impacting overall survival for a population, it spends a tremendous amount of money, a tremendous amount of anxiety with screening tests, with little fruit to back that up in terms of overall survival with our current technology. And we'll have to carefully study these new technologies, because they could be very sensitive at detecting early cancers, but it will take a lot of study to determine how to use that and how to act on that, and see that does it really reduce the incidence of ovarian cancer. And those studies are costly and will take many years of study to really bear fruit. Natalie, any other thoughts?
No, the two strategies that I'm most familiar with are the Pap smear strategy, or the vaginal collection strategy, whereby cells are or DNA or biomarkers are being explored. And then, of course, the cell-free DNA is the other strategy that I believe is being explored. And I agree with Dr. Nguyen, more than likely, cell-free DNA is the least invasive, and it's probably going to be the winner ultimately.
I've got one last question that came in for Dr. Mckenzie. You mentioned some psychological effects these women face. What is the suicide risk? What would you do, or how would you identify a patient with suicidal thoughts?
So luckily, we find in our practice that the suicide risk is low, but it's not negligible. Most institutions have the emotional wellness vital sign that is explored when patients' other physical vital signs are being explored at entry into a practice. And these very short screening questions seek to better understand a patient's emotional acuity and intensity, and thereby alerting the other providers in a practice so that referrals can be made. And when we do identify these acute issues, we usually address them rather quickly with help of our mental health counselors and the rest of the mental health team.
Thank you very much. I think that's all the questions. We'll wrap up the Q&A now and move on with a presentation from Dr. Michael Diaz on patient advocacy.
Hello, I'd like to welcome you to the advocacy portion of our Flasco Living with Cancer series presentation tonight. My name is Michael Diaz, and I'm a medical oncologist and hematologist. I'm the Flasco Director of Patient Advocacy and a past president of Flasco. I practice medical oncology and hematology in St. Petersburg, Florida with Florida Cancer Specialists. And we're here today to talk about something that's pretty near and dear to my heart, and it has to do with patient advocacy. And so first of all, I'd like to start off more from the big picture perspective. I've had people tell me in the past, well, Mike, talk about advocacy. Tell them what it means. Well, I looked up the definition of advocacy in the dictionary, and all it says is to advocate. Very helpful, huh? So let me just explain. So advocacy, as far as I'm concerned, yeah, it's a general concept, but it means to advocate for, which means you're trying to do something to benefit somebody, whether it be yourself or somebody else. In fact, you all being here tonight to educate yourselves means you're advocating for yourself in the form of education, educational advocacy about a condition that might mean something to you or someone you know or care about. So yes, there's educational advocacy. Your doctors will also most likely advocate for you whenever they're fighting insurance companies to get scans or medications or therapies or testings approved. We really don't get paid any money to do that, and that's we either have to hire staff to do that or we do a lot of it ourselves too, but we're advocating for you. The way, and there are many other ways besides education, you can advocate for family members. You can help assist with certain components of their care, and all that is advocating. There are lots of ways to do that. The main way that I like to advocate for my cancer patients, because that's one of the reasons why I love being a doctor. In my free time, which is not a lot of, but I do spend a lot of time doing it, is I advocate for my patients when it comes to healthcare reform. One of the things that I noticed as I was going through my training as a young oncologist is that it didn't seem to me that there were a lot of healthcare providers involved with the policy decision-making process that would impact patient care, patients' healthcare, or their access to care. And one of the things that I've been doing since I've been practicing medicine for a little over 15 years now, I've been getting more and more involved with advocating for healthcare reform so that patients have access to affordable quality healthcare that's close to home. I'm a firm believer that we have enough resources in this country. There's no reason why people shouldn't have to spend their life savings or you know, refinance their house just to get their cancer care. I think it's ridiculous. I personally think that the system is flawed in a lot of ways. And I think that there are a lot of people who are getting a disproportionate share of the resources, and those are not the patients, and I personally don't think they're the providers either. So that's one of the reasons why I'm involved with healthcare reform. And we do it in a lot of ways. I work with organizations of like-minded individuals, whether it be other oncologists or pharmacists. We have organizations. We work to advocate here in Glasgow, mainly at a state level and also at a national level. But I do work with other organizations for synergy. And it all has to do with in understanding the healthcare system, which is extremely overly complicated. It needs to be fixed, but it's what we have, and we have to understand it to understand where the problems are so we know where we can fix things. So if we need to, instead of guessing, we will perform studies or commission studies to be done to better understand the little nuances of how potential things are impacting patient care or access to patient care. And then we also spend a lot of time educating our elected officials on this process, whether it be local in Tallahassee, whether it be going to DC, which we don't do a lot of traveling now, but I previously I would go to DC at least twice a month to help educate our elected officials there. We have to network a lot with Health and Human Services as well as Center for Medicare and Medicaid Services. And at a state level, we have to work a lot with the governor's office, the insurance commissioner, as well as Florida Medicaid for a lot of patient issues. And just to give you an idea of how effective you can be sometimes, for those of you all that aren't aware, about 4 years ago, the previous administration attempted a demonstration project that we will call the Part B Medicare Demonstration Project. And they thought, oh, we're going to save money, we're going to reduce the cost of care. And unfortunately, all it would have been doing was restricting access of care to possibly 50 to 75% of Medicare patients across the country, because it basically refused to pay for the more expensive treatments. Well, if you have cancer, you know that a lot of the time, the most effective treatments are the more recent treatments and are going to be the more effective treatments. Well, they were going to try to encourage you to use more generic medications. Well, the generic medications in cancer care are over 10 or 15 years old, and they're fairly outdated and not usually as effective as the newer medications. So it would have negatively impacted patient care. We went to grassroots across the country. We had to have all of our patients contact their representatives and their senators and tell them that they needed to shut this down. We were very successful in that it never took place. In fact, the following year, I went to meet one of our senators' healthcare aides, and she said, you don't need to introduce yourself to me. Because of you, I had over 3,000 emails in my inbox. My email was locked. My email account was locked for several weeks. She said, you did a great job with that. The senator wasn't listening to me, but when he saw how many people were concerned about this project, he said he realized he had to listen. So we can work together, and we'll talk more about that. I would like to move the discussion onto a more timely, more relevant, more current issue, which is known as pharmacy benefit managers. And most people aren't aware of even what a pharmacy benefit manager is. And just to give you a little background, the pharmacy benefit managers are who your insurance companies hire to manage your oral prescription benefits. They started off as just claims processors back in the 80s and 90s. All they would do is process insurance claims for oral medications. Well, over time, they evolved, they coalesced, they merged to the point to where there are essentially 3 pharmacy benefit managers that manage the oral prescription benefits for nearly 80% of all Americans. That's a lot of control and influence. Well, what happens when you have this control and influence? Stay tuned, we'll talk more about that. But these pharmacy benefit managers are so lucrative from a business perspective that they are merging with the top largest insurer companies in the country. In that one of the largest pharmacy benefit managers, CVS Caremark, recently bought one of the nation's largest insurance companies, Aetna. Well, 3 of the largest pharmacy benefit managers are owned or own some of the top 4 largest insurance companies in this country. So there's a lot of vertical integration going on. And it's because this component of healthcare has become so profitable. It's like, well, why has it become so profitable? Well, these pharmacy benefit managers, and more we're learning about this. In fact, this gets us to something that's near and dear to my heart, the price of drugs. I think the price of drugs are crazy. They're astronomical. They're very high. And it's difficult for patients to get their care because these newer medications and treatments cost so much. Well, studies are showing that when it comes to brand name drugs, we don't even talk about generics. It's a lot more complicated. Brand name drugs, probably well over 50% of the cost of any drug, whether it be oral drug or IV drug, over 50% of that is going to somebody else as a rebate. Yes, over half the cost of drugs. So if you're on a drug that costs $1,000 a month, over $500 of that is going to a rebate in somebody else's pocket, not the pharmaceutical company's pocket. So a lot of people like to complain to the pharmaceutical companies about drug prices, and I'm not letting them off the hook. But when I meet and I talk with a lot of the senior national executives in pharmaceutical companies, and they're aware of my stance that drug prices are too high and they need to get them under control and they need to do something about it. But part of the reason why the costs are so high is because of these rebates that are given out. Well, these rebates are from the drug companies, but they have to be built into the cost of the drug. And one of the nation's largest recipient of rebates are these pharmacy benefit managers and or insurance companies. Yes, the US government via Medicaid and the VA healthcare system, they get some rebates. And they are a decent sized percentage of those rebates, but nowhere near as large as the rest of the rebates. In fact, some studies are showing that well over $150 billion a year in 2019 dollars was spent on rebates. And that's one of the reasons why the cost of drugs are so high. And when I talk with the senior people in pharmaceutical companies, they are somewhat traumatized after they have discussions with these pharmacy benefit managers because they have to talk with them and set up contracts before the pharmacy benefit manager will make their new medication available to the lives that they cover. And this is a typical comment I hear about that a pharmacy benefit manager would tell a pharmaceutical company. Wow, we really like that drug, your new drug. It's great, and we'd love for our patients to have access to it. But they need to know that we're working for them. So up front, we want you to give us a 10% discount off of the price so they can see we're working for them. And then after they've paid their copay, and after all the claims have been processed, on the back end, we want a 50% rebate. Otherwise, they will not even know your drug exists from us. And so these guys, they want their drugs to be available. And like I said, 3 of the largest pharmacy benefit managers control nearly 80% of the prescription benefits. If you don't let them have what they want or some version of it, your drug's not going to see a lot of patients or not even have the possibility to be used for a lot of patients. So there's definitely an issue with the rebate system going on, but also on the other end, the pharmacy benefit manager will also go after the providers. When I say the providers, the pharmacists, or in the case of cancer patients, if the cancer doctors are providing the drug, even the oncologist. They like to come back to us about months after the transaction occurred, i.e. the prescription was given, and they'll just come back and say to the provider, either the cancer doctor or the pharmacy, and say, yeah, you owe us 10% of all this money. And it's like, why do we owe you 10%? So, well, you didn't meet quality measures. And this is exactly what was told to my practice. You didn't meet quality measures. It's like, we didn't know that there were quality measures. They said, well, you're correct. There's not any oncology or cancer specific quality measures. So, we looked at the cancer patients that you're taking care of, our cancer patients that you're taking care of, and we looked at their adherence rates to blood pressure medications, diabetes medications, and cholesterol medications. And well, they were all perfect and they were adhering to their medications. So we couldn't use that data. So we looked at the entire Southwest Florida regional adherence rate to blood pressure medications, to diabetes medications and cholesterol medications, and we applied that to you. And because the compliance rate in Southwest 4 is not very good, you've got to pay this penalty. And, you know, my people know that if we don't pay this, what's called a DIR fee, direct and indirect remuneration fee, then we get kicked out of network. We can't take care of our patients. And trust me, if we can provide the oral medications to our patients, they will have much better patient care than if it's provided by some third-party specialty pharmacy that's nowhere near here, that knows nothing about patients or patients' care. So we do what we can on our end to try to sustain those fees. But those are just examples. Now, that's how they affect the business end of thing. That's how they affect the pricing end of thing. But in order for these pharmacy benefit managers to make more money and to steer more traffic towards certain products, they develop these formularies. And these formularies are, I guess you could say, their versions of preferred drug lists, and that drugs that they like, and some might even say, yes, that might be the appropriate indication for the drug, but are they getting higher rebates on this drug, and that's why they like it or not? We don't know. All that information is privileged and considered to be proprietary. But they have these formularies, and we're seeing perfect examples of how these formularies that they're trying to implement on cancer patients, they don't really work. You have cancer, you know that you may have other unique healthcare conditions, and it's not like there's a plethora of medications with which you can choose from, which some might consider to be your best treatment option. Why? Because different medications have different adverse side effects, and some may have an adverse side effect profile that may be detrimental to you given your unique health characteristics, or may not be better for you given your unique cancer. And so it's very difficult to say that just because I have cancer and it is cancer type X, that you should always start off with this one medication that these pharmacy benefit managers are saying you should start off with. And I can give you a perfect example. Let's tie it into patients. One of the things that we do is that we collect what's called patient PBM horror stories. And I do want you to know, if you have had any of these horror stories, as I will be talking about in a minute, please type in the little text box your name so that we can, and the best way to reach you so that we can reach out to you at Flasco and get your horror story recorded. We do this at the Flasco level. We do it at a national level. I do it with a national organization I work with called Community Oncology Alliance. If you go to pbmabuses.org, that's P as in Paul, pbmabuses.org, you can see, unfortunately, volumes of horror stories that have resulted from these pharmacy benefit managers negatively impacting patient care. Just to give you an example, getting back to the formularies that we were talking about, we have several examples that have even happened here in Florida where a patient with a condition and other cancer and other medical conditions, for example, like bad kidney disease, should be getting, if you look according to routine formularies and what's considered to be the #1 line of therapy, a medication that its #1 side effect is that it can impact the kidneys. Okay, well, one of my partners saw this patient and realized, wait, this patient needs this medication. It could impact the kidneys. They have bad kidneys. Then maybe we need to start them on the second line medication first, period, and avoid this potentially more dangerous one. They sent the patient to a local cancer center of expertise, and their specialist in this cancer said, yeah, you can't have that #1, that first drug, that first medication. You need to start off with the one second on the list because it could hurt the kidneys. Well, it took the pharmacy benefit manager over 2 months to approve the medication because it was denied because it wasn't #1 on their formulary list. So we have several examples of where they can delay access to timely care. We even have examples nationally of patients just dying while they're waiting for their medication to arrive. An unfortunate example of a patient who waited 9 weeks for a routine metastatic breast cancer medication to arrive, but the pharmacy benefit manager fought with the provider for so long, the patient gave up after 8 weeks, went into hospice. The medication showed up just after that, but the patient was too weak to even take the medication. We have other examples of where the pharmacy benefit manager, I have 2 examples in my practice, not with me, but with 2 of my partners, of where the pharmacy benefit manager actually said, no, we know this medication is front line and is the first one that's listed to be used, but we think the patient should have surgery first. And in both instances, even the surgeon and the medical oncologist said, no, 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 surgery is contraindicated in this patient. They said, well, no, we think the patient should have surgery first. So they're making a medical decision without even seeing the patient. They're making a medical decision without a license to practice medicine. And that's one of the things they're doing to save money and to help their bottom line. These guys are businesses. They took an oath to their shareholders. They did not take an oath to patients like the doctors did. And so if you have a horror story, please type it in on the question box so that the people from Flasco can contact you, hear your horror story so we can get it documented. We need to have these documented. And part of the reason why is that we are working on trying to reform the healthcare system as far as these pharmacy benefit managers are concerned. We're working both at a state level and at a national level. To give you an idea of what we've been doing at a state level, in fact, we've been coordinating with other healthcare advocacy organizations, and we attempted to have legislation passed last year for pharmacy benefit managers. It would have held and made sure there was transparency as well as accountability, because right now there's no transparency. I was in DC a couple of years ago and was talking with some key staffers on both the Senate and the House, and they said, yeah, the pharmacy benefit managers people were up here yesterday and they were lighting their hair on fire saying, oh no, we can't be transparent. That will disclose proprietary information. We won't be able to save money. There's no way we can be transparent. Well, you know, this is healthcare. Everybody needs it. And if you have to be that transparent, then is there a reason for that? So we want reasonable transparency and we wanted accountability. And unfortunately, that bill did not pass. It did not go up for vote in the House or the Senate, but we will be working on that again for next year. And that's one of the reasons why I want to grab your attention. We will be working on that next year, and we will need your help with reaching out to your legislature, your state representative and your state senator, so that they will know they need to support this bill. Now, with that being said, to give you a little bit more of an idea of how conniving these pharmacy benefit managers can be, one of our other organizations developed a study looking at Florida alone, just to better understand how these pharmacy benefit managers worked in the Medicaid system that's run by the state. And just in one example, with a generic medicine, they saw that the pharmacy benefit manager was paying a pharmacy that they didn't have a preferred contract with. They're paying this pharmacy approximately 20 cents a pill for generic medicine the patient needs to take twice a day. And they were paying a pharmacy that they had a contract with. Now you got to keep in mind, this contract that they have with the pharmacy is not accessible to the public. Why? Because it's proprietary. Well, they were paying them $10 a pill. And when you sit down and you look at things, it would not be reasonable, given the fact this medication is taken twice a day, every day, within a year, if you assume a reasonable number of patients are on this medicine, it's a commonly used medicine, very commonly used medicine, that it wouldn't be reasonable for there to be a $30 million discrepancy going into this preferred pharmacy's pocket. So that has caused a lot of uproar in Florida. That was not able to get this legislation passed, but it was able to get the governor to hire a nationally renowned actuarial firm to do their own study to validate and verify what this other study has seen. If there's that large of a discrepancy, then if it's the taxpayers' dollars, I think the taxpayer deserves to know, why is this pharmacy getting paid so much more per pill than your average pharmacy? Okay, that stuff needs to be known. There's been a lot of reform going on at the state levels because of little tactics like this, especially in Florida, especially in Ohio and Georgia. We want Florida to be next, and so we'll be reaching out to you to advocate more next year. We're also working at a national level in DC with a couple of different bills, a couple of pieces of legislation, one so that patients could get their drug within 48 hours and they wouldn't be waiting several weeks or even months to get their medication. Now, some of that stuff's been put on hold because of COVID, but we plan on bringing that up at the beginning of next year, because right now, with the way things are in DC, not a lot's happening at all within the next several months because of COVID, because of the elections, but we are working on it as we can. So your involvement is essential. As I told you with the example, when it comes to healthcare reform, if your elected official hears about you, the voter, and they hear that you are concerned, they will listen. And we are planning on this next year, for this next 2021 legislative session, we are planning on having a bill introduced to help reform pharmacy benefit managers, but we need to have a coordinated effort, because there might be more than one bill out there. We want to make sure that you are sponsoring the correct bill. We want to make sure that you know why. So it's a good idea, I think it would be, if you are interested and want to help verbalize your opinion as a voter to your elected officials, that you put your name and email in the question box. Let them know you want the monthly newsletter. It's a monthly patient newsletter. That's one way to stay updated. Not only will you learn about advocacy issues, but you will learn updates about all the different things that we talked about today. And just as well, you can go to the website at www.patients.plasco.org to learn more about not only advocacy information, the things that I'm talking about here today. Once again, it's to make sure there's a coordinated effort so that you know when to reach out to your elected official, you know what to talk about, you know which bill to tell them they need to support, but it's also to learn more about other things for patients, such as assistance programs, various support groups, as well as clinical trials, and yes, of course, something important and dear to me, information about advocacy. And also, we plan on notifying all the patients that have participated in these Living with Cancer series when there is a time we need to call them to action, because you can help us, the providers, make sure that you have access to care that's affordable, quality, and that people are not taking all the money that's being designated for healthcare, instead of it going to the patients, they're putting it in their pocket. We got to put a stop to that. So I appreciate your attention, and please sign up for the newsletter, go to the website. Any questions, once again, please direct them in the question box. Your questions will be answered, but you all have a great evening. Thank you. God bless.
Thank you, Dr. Diaz, for sharing these important points. And thank you for your advocacy, and thank you for your passion. If you would like to be added to the mailing list for advocacy updates, please feel free to submit your email in the questions box on your GoToWebinar panel. I'd like to thank all of our panelists again for presenting this evening, for volunteering your time, and for leaving us with this important information. I'd also like to once again thank AstraZeneca for sponsoring this webinar. As a reminder, all of the handouts mentioned in this webinar can be found in the handouts Dropbox on your GoToWebinar panel, so make sure you download them now. Additionally, this webinar was recorded, so if you missed anything and want to hear it again, it will be available on the Flasco website soon. Thank you for joining us tonight, and we hope that you would join us for more webinars with Flasco in the future. Thank you again, and have a good evening.